I'm very excited to be back at the Lakewood Church. I'm so excited to see how this summit has grown in size and stature. It's just amazing. Paul Osteen is just an extraordinary individual, and he and his colleagues have really done an amazing job at building this and getting the word out. And I'm so thrilled to be a part of it. I'm local. I live and work here in Houston. I'm at the Texas Medical Center where Texas Children's Hospital is. So I'm both a research scientist and pediatrician over at Texas Children's Hospital. And at the same time, I'm an academic dean at Baylor College of Medicine right here. And I've devoted my life to this interesting problem of getting people to care about something called neglected diseases, which is an interesting problem. So I'm going to tell you about what we've been doing to raise awareness about what I sometimes call the most important diseases you've never heard of, and what we're doing to provide access to treatment for these diseases in low-income countries of Africa, Asia, and Latin America. I'll also tell you a story about the surprising level that these diseases occur right here among the poor in wealthy countries, including the United States, which is often a surprise to people. And then I'm going to finish up by telling you what we're doing about developing new interventions like vaccines for these diseases. And the more interactive this is, the more fun it is for me, and I hope you as well. So I'll try to throw out questions as I go along. But also, rather than just wait for questions at the end, I love to be interrupted and to be asked questions, or if people have comments or want to share experiences, that's totally fine. To me, that makes it more meaningful for me as well. So I'm going to start here. I don't know if we can get those lights down in front at all. Is that possible? Because these are dark slides. I don't know how well they show up. I'm going to start out talking about something called the Millennium Development Goals. How many people have heard of them? We sometimes abbreviate MDGs. That's pretty good percentage of you. I don't know if there might be some light switches up here in the front, and then maybe that's the trick. What happened was in the year 2000, at the start of the 21st century, this guy in the front here, it was a Ghanaian by the name of Kofi Annan, was Secretary General of the United Nations. He just passed away a couple of months ago. And what he did was brought all global leaders to United Nations headquarters to deal with the plight of what were then called the bottom billion. And what did he mean by the bottom billion? Anybody? The world's poorest people, right? At that time, the estimates were of the population of the planet around 7 billion. Roughly 1 billion people lived on no money, lived below the World Bank poverty figure of $1 a day. And they all got together and they decided, we've got to do something about this. And a lot was happening at this time. This is the time when the Bill and Melinda Gates Foundation started. And there was a general awareness that this was a time to do something. And what was done was to bring all global leaders to United Nations headquarters on the east side of New York, and that's what you're seeing there in that picture, to draft these goals. And now I'm not a big fan of United Nations documents. I think most of them are forgotten about as quickly as they're drafted. But this one is stuck and has provided a very important framework for global poverty reduction. And for purposes of this conference, one of the game changers was that for the first time, people were linking health to poverty. In other words, these diseases not only occurred in the setting of poverty, but were actually a stealth cause of poverty. So 3 of the 8 Millennium Development Goals for lifting people out of poverty were actually around improving health. And that was number 4, represented by that little teddy bear, to reduce child mortality. Number 5, to improve maternal health. And number 6, to combat AIDS, malaria, and other diseases. And it turns out number 6 probably has had more impact than all the other goals, because it was backed by lots and lots of dollars from wealthy nations to support coordination. So for instance, coming out of number 6 to combat AIDS, malaria, and other diseases was PEPFAR. Anybody know what PEPFAR stands for? Since you're paying for it? Actually, you're paying a lot for it. You're paying around $8 billion a year for it. So it's a serious cash, right? And that's called the President's Emergency Plan for AIDS Relief. It was launched by President George W. Bush to put people on antiretroviral drugs for AIDS prevention, and so literally millions of people in Africa, Asia, and elsewhere have been allowed to be access to AIDS drugs because of PEPFAR. It also launched something called the President's Malaria Initiative to put people on anti-malarial drugs and bed nets. Globally, it launched something called the Global Fund to fight AIDS. Somebody added tuberculosis and malaria, same kind of thing, to put people on antiretroviral drugs, provide bed nets and anti-malarial drugs. And this is now making a huge difference. We're starting to see dramatic reductions in the number of people who die from HIV/AIDS and also malaria. But that's not what I came here to talk to you about. What I came here to talk to you about is a problem with this Millennium Development Goal number 6. So read the goal again and tell me if you see a problem. Somebody said it, yeah. Other diseases, right? Believe it or not, something called other diseases didn't get anybody very excited. And you never saw this happen. This never happened, right? Where you've got Bono and Tony Blair and Bill Gates at the World Economic Forum standing up there saying other diseases, right? So that was a problem. And those of us who worked on other diseases said, oh, this is incredible what's going on with putting people on antiretroviral drugs for AIDS and what's going on now with malaria. But that's not the diseases that we are devoting our life to. All of our work for the last few decades has now been lumped into other diseases. And so a group of us got together, mostly myself and a colleague named David Molyneux at the Liverpool School of Tropical Medicine and Alan Fennick at Imperial College London. And we went about and did a branding exercise. We said, calling something other diseases is a non-starter. And we kind of made up a term. We started calling them neglected tropical diseases, or NTDs. And it turns out it's not a perfect term because even though we call them tropical, they're first and foremost diseases of poverty. So maybe that wasn't the best term, but now the term has been catching on. And it referred to, and I'll show you the list in a minute, the original list of NTDs had 13 or 14 tropical infections that were highly prevalent among the poor. They're endemic in rural areas of low-income countries, but also some urban areas as well. They actually tend to be ancient afflictions. So anyone heard the term emerging infections? What's an emerging infection? Something like Ebola, something that we didn't know exists, all of a sudden it exists. And this is just the opposite. These have been around forever. So you could find the diseases that we're talking about today, you can actually find descriptions of these diseases in the Bible and other ancient texts. They tend to be chronic and disabling diseases. And they cause blindness, they cause growth delays, they cause disfigurement. Many of them are not killer diseases. In fact, most are not killer diseases. And that's a problem when we're trying to raise awareness, and I'll go into that in a minute. Many of them are disfiguring. What's an example from the Bible, for instance? Now, you probably could figure one out. Leprosy, Hansen's disease, absolutely. That's a neglected tropical disease. So they're often highly stigmatizing. The other part about them, they not only occur in the setting of poverty, they cause poverty because they make people too sick to go to work. They actually shave IQ points off of kids when they're growing up. They really affect pregnancy outcomes. And so we put a lot of effort into raising awareness about them. In fact, this is when I wrote my first single author book. It was called Forgotten People, Forgotten Diseases. It was a hard slog getting the word out about this book. In fact, my kids used to call it Dad's Forgotten Book on Forgotten People with Forgotten Diseases, as only loving children could do. And of course, now it's in its second edition. It got translated into Japanese, so it's starting to kind of catch on. And here's some examples. The numbers are extraordinary. So this is a disease that you may know as elephantiasis. It's officially called lymphatic filariasis. It affects more than 100 million people in low and middle income countries. And here's the problem. This individual says, it's quite a problem for me when I have to stand at work for long periods. So he's too sick to provide for his family, so it traps his family in poverty. The point is, these diseases are so ubiquitous among the poor in places like Africa and poor areas of Asia that we can actually show how it blocks economic development as well. The problem from the advocacy perspective is these are not killer diseases. So why is that a problem? Well, imagine I'm at a summit on Millennium Development Goal number 6, and you have, I'm sitting next to two other disease experts, one on HIV/AIDS, one in malaria, then myself. What's the HIV person going to say? Yeah, AIDS orphans. He or she gets up, spouts out the numbers of deaths, and sits down and talks about AIDS orphans. That's all you have to do. The malaria person. Anybody hear malaria talk recently? Right, they're the most obnoxious of all of them, right? So what do they say? What do they say? In the time we've been talking, 200 children just died of malaria, right? And then I get up there, right? And well, these are chronic and debilitating. It's not a 30-second UNICEF commercial. It takes time. So we still have to really refine our message. Here's another one. Probably the most common gynecologic condition on the African continent, called female genital schistosomiasis. How many people have heard of it? Not a lot, right? So, not amazing, the most common gynecologic condition on the African continent, most people. And this is an educated audience, right? Imagine what it's like in the rest of the world. So this is a parasitic infection that affects an estimated 250 million people, 90% of the cases in Africa. We estimate and it's a parasite that lives in the bloodstream and deposits these spine-shaped eggs that get into the bladder and the liver, and we knew about that, but only recently did we realize that nobody had ever bothered doing a colposcopic exam on the girls and women with this condition. And up to 75% of them have those same lesions on their cervix, uterus, lower genital tract. It's a cause of pain, bleeding, stigma, depression. And now 2 large studies have linked it to a 3- to 4-fold increase in HIV/AIDS transmission, probably because the ulcerative disease in the female genital tract is providing a conduit for the virus, although we still don't really understand the mechanism. The point being, this may be Africa's most important cofactor in its HIV/AIDS epidemic, and no one's heard of it. So here are the most recent numbers from a study supported by the Gates Foundation, what we're part of, called the Global Burden of Disease Study. And it's not important you remember the specific numbers. And you can actually download these data yourself if you go to healthdata.org. It's put out by the Institute for Health Metrics and Evaluation. It's a nice tool that you can use. Thank you so much. It's a nice tool that you can use to look at the numbers. But just look at the numbers. 447 million people with ascariasis and these are included in the list of neglected tropical disease. Our original list had 13 or 14. The World Health Organization took that and they expanded it to about 20, which I also think is a pretty good list. So ascariasis, 447 million people. Trichuriasis, what's trichuriasis? Whipworm infection, 289 million. A lot of these are wormy diseases. There's hookworm, scabies, 175 million, schistosomiasis, dengue, foodborne trematode infections, lymphatic filariasis, onchocerciasis, Chagas disease, cysticercosis. The point is every single person living in extreme poverty has at least one of these neglected tropical diseases. So what are we doing about it? Well, for the most common diseases, which includes those 3 intestinal worm infections, schistosomiasis, and scabies, the big pharmaceutical companies like GlaxoSmithKline and Merck and Company, as well as the German Merck, J&J, and a few others, have actually been scaling up production of medicines for these diseases and donating them. In many cases, they were developed for one purpose for diseases in the West, like in the United States and Europe, but it actually turned out to work for a disease in a poor country. And let me give you an example. Zithromax. How many of you have taken a Z-Pack? Anybody not take a Z-Pack in the last year? Right? What do you take it for? Your community-acquired pneumonia. You take it for your strep throat, your otitis media, your sinusitis. Pfizer makes $1 gazillion on it, but it also works for trachoma. And so the idea is that you could administer, because the safety profile of these medicines is so good, it doesn't have to be administered by a healthcare professional. It could be administered on a once-a-year basis and actually lower the prevalence of these diseases in the case of trachoma. In some cases, actually interrupt transmission as a public health problem. And often these are even sometimes given out in schools by school teachers who are trained to give out the medicine like you're seeing here. So what we did back in 2005 was we wrote this almost 15 years ago. We wrote about the concept of combining these different interventions in a package of medicine. And the package of medicine included either albendazole or mebendazole to target the intestinal worm infections, praziquantel for female genital schistosomiasis, ivermectin for lymphatic filariasis as well as river blindness, and Zithromax for trachoma. And we noticed that wherever you see on this colored map over here, there's a lot of overlap, a lot of geographic overlap. So the point is the same person who gets elephantiasis is also getting intestinal worms, is getting schistosomiasis. So we can combine them in a package. And we costed it out because the pharmaceutical companies are willing to donate the medicine. We've taken out the cost of the medicine because it could be just given once a year, sometimes twice a year. We estimated we could do this for 40 cents a person per year, which is nothing, right? I mean, look at the range of costs here. Here's the cost for a year of antiretroviral drugs, which was still a good public health buy, a year of direct observed therapy for tuberculosis, malaria, and there's our package of medicines that we call the Rapid Impact Package because we wanted to give it a cool name. And it's 40 cents a person per year. And so what we did was we wrote these 2 back-to-back papers in the Public Library of Science about this opportunity, and then we got kind of stuck because we were academics. So, if you're an academic writing a paper in a journal, what's the reason you write the paper in a journal? To get published and keep my job. No, not trivial stuff. Remember 4 kids, right? What? More funding, get grants. And why do we write grants? To write more papers, right? Why do we write papers? To get more grants. That's what academics do. But the problem is we wanted to get people to care about this problem and actually scale it up and deliver it, and to raise money through the US governments and my colleagues at the UK governments. And that was a problem because we were doing this for something called neglected tropical diseases. And so one of the messages that I have, if you're a scientist or a physician, don't underestimate your power to affect change. With a little providential help as well, I think, because what happened was at that time I was chairman of microbiology at George Washington University, and I would literally get in a taxi and on my own dime go to the congressional office buildings, the Senate, the Congress, and even the executive office buildings of the White House. And at that time you could go in and not get arrested and explain to important people why they should care about this intervention and how low cost it is. And it worked. It also turned out my timing was very good because at that time the Bush administration had just launched PEPFAR, and they were so excited about it they were looking around for another big global health thing to do, and so our timing was really good. The other thing that happened was this was an unusual period in our government. This was during this period, Republicans actually spoke to Democrats, and Democrats actually spoke to Republicans. Things weren't as terribly polarized as they are now. So the International Business Times wrote this story about how 3 scientists marketed, and it really was a marketing exercise, neglected tropical diseases, and raised more than $1 billion. So the World Health Organization just reported that more than 1 billion people have now received this package of medicine. And we've just published now the impact working with the Institute for Health Metrics and Evaluation. And for some of these diseases, like lymphatic filariasis, we're seeing a 44% reduction in the number of cases, to the point now where some countries are actually talking about eliminating this disease as a public health problem. And so far we've seen about a 1/3 reduction in the others. For hookworm, for reasons which we can talk about, not as much. The point is this is having a big impact on reducing the prevalence of these ancient, in some cases, biblical diseases. The other thing that happened was we started seeing some collateral benefits which we don't understand. So our colleagues at UCSF found that the azithromycin component of this package was reducing child mortality in places like Ethiopia by 50%, a once-a-year Zithromax of reducing child mortality by 50%. What's going on there? Why would that happen? Because trachoma that it was targeting is not a killer disease. Why is overall mortality going down? Maybe. It's actually a trick question. We have no idea. We were just all of a sudden 50% reduction. So, I mean, is it that it's reducing carriage of pneumococcal bacterial pathogens? Is it reducing diarrheal disease? So we're just seeing these extraordinary benefits that we never would have thought. The other unexpected piece to this is when you deliver ivermectin, which is a medicine in the package, if you can get ivermectin levels high enough, it's toxic for mosquitoes. So if mosquitoes are feeding on blood, like the ones that transmit malaria, they die. So this may turn out to have collateral benefits of reducing malaria. So we're putting this all together now in a paper that's under review at the New England Journal of Medicine. It's basically saying, totally unexpected things that happened. I'm not calling it that, of course. It's got a more elegant title than that, but that's basically what it is. Unexpected things that happen when you give this package of medicine. That's the good news part of the story. The problem was, just as all of us were kind of high-fiving each other and congratulating each other on the success of the package, as John Lennon likes to say, life is what happens in between plans. This started to happen. We started to see these next generation 21st century forces actually promote the rise of a new crop of neglected tropical diseases that we have to manage. And the forces that are driving it it took us a while to understand, and we still to say we understand it would be an overstatement. We're just seeing this association, and we're trying to understand the basis by which it's happened. And this is a list of 3 of the big drivers that we're having, and I'm going to add a 4th one, which is urbanization. But it looks like political instability and conflict, the shifting nature of poverty that I call blue marble health, and I'll explain that in a minute, and climate change is having a big impact on causing neglected tropical diseases to come back. So even though we're knocking them down with this package, we still are not solving the problem for other neglected tropical diseases. So let's look at war and conflict. Why would war and conflict promote neglected tropical diseases? Yeah, destabilization. You said infrastructure, right? You can't implement public health control. And so when we actually did this analysis with the Institute for Health Metrics and Evaluation of the countries with the highest prevalence of neglected tropical diseases, most of them turned out to be conflict and post-conflict countries. So here's the best example, right? What's going on right now in the Democratic Republic of Congo, especially in Eastern Congo, with the collapse of the health system there, right? The Ebola in 2014 arose out of Guinea, Liberia, and Sierra Leone, not so much because it was tropical, but because the country had been decimated by by decades of civil war and conflict and totally collapsed the health system. And we're seeing that play out in the Democratic Republic of Congo. What's the worst place on the world probably right now in terms of conflict and post-conflict? Sort of what am I thinking? Yes, people say Syria. Yeah, so the former and current ISIS-occupied areas of Syria, Iraq is a disaster now. We're seeing not only the return of things like measles and polio, but also leishmaniasis, schistosomiasis, a lot of our neglected tropical diseases. International borders are collapsing, so animals are being trafficked like never before, so we're seeing a lot of zoonotic diseases transmitted from animals like brucellosis. So this is causing a horrific problem. One of the ones that we're dealing with right now is a neglected tropical disease that we're making a vaccine for called leishmaniasis, but the locals call it Aleppo evil. So this is a parasitic infection caused by a leishmania parasite, a microscopic parasite that gets into the skin through the bite of a sandfly. And as the garbage piles up in Syria and Yemen and Afghanistan, the sandflies are proliferating. Even on a good day, these countries struggled with the control of leishmaniasis, and now with the collapse in Yemen and Afghanistan, Iraq, and Syria, there's been a dramatic rise, a 100-fold rise in the incidence of these diseases. And kids especially are getting disfigured. They're not dying from this disease, but they're getting disfigured because they have permanent scars on their face. And who gets hit the hardest? Girls and women, right? So girls and women are now rendered unmarriageable. It's grounds for spousal abandonment. It's just again, no one's dying, but you can imagine the extent of this problem. And one of the things that we're really struggling with is working with the global health policymakers, including the Gates Foundation, because it's not killing. What's a metric you can use to explain to something like the Gates Foundation or others why people's lives are being destroyed by permanent scars, facial scars of leishmaniasis? I know everybody in this room gets it, but the policymakers, they want numbers, right? And we don't really have good numbers. We have this thing that we call DALY, the disability adjusted life year. It's not quite doing it for us so far. So we need a better way to kind of articulate that and express it. What's going on in the Western Hemisphere? Venezuela is collapsing now, right? So guess what's happening? Massive recurrence of Chagas disease. In fact, Chagas disease is so now widespread in Latin America and in Venezuela that when people prepare the fruit juices, they're crushing kissing bugs in the fruit juices that contain the trypanosome. So you're getting oral infection with Chagas disease. Leishmaniasis, a Latin American form of leishmaniasis, is taken off. Urban schistosomiasis. We've just now wrote a paper that just came out yesterday in Lancet Infectious Diseases about the malaria situation there. So people are so desperate for employment that they're headed towards the gold mines. And the gold mines have no malaria control practices. So people who've never been infected with malaria are headed to the mining areas, and they're getting malaria, they're dying. It's really quite a disaster. Dengue, chikungunya, Zika is taking off. And this is where we're fighting measles as well. So measles, Venezuela led Latin America. 20 years ago, Venezuela led Latin America in terms of control of measles and other infectious diseases. And now it's all back because vaccination programs have stopped. And in that map there, it shows that area in red where the measles cases are leaching into Brazil, into Colombia and Ecuador. What's going on there? Yeah, it's one of the largest diasporas globally right now, but some say the diaspora coming out of Venezuela may even dwarf the one coming out of Syria and Iraq at this point. So this is destabilizing the whole region with neglected tropical diseases. And then we're starting to see things like this, which is the recurrence of yellow fever in Brazil. And here, we don't think it's so much economic collapse. We think something else may be going on other than conflict or political instability. What might be happening in Brazil? Although the economy is also suffering as well. What else might be going on in something like Brazil? Well, I mean, certainly there has been the health system is not as strong as it was a few years ago with all the corruption and the economic collapses in Brazil. Deforestation and climate change, right? So we think climate change may be having a big role in that. And so we're seeing this uptick. You know, over the last few years, we've seen this big rise of Zika, chikungunya, arbovirus diseases transmitted by mosquitoes, Zika, chikungunya, dengue, yellow fever. We think climate change may be having a role in it. But the problem is climate change doesn't occur in isolation. Things like economic difficulties in Brazil are happening at the same time. So really pinning it down is really difficult. And it's especially a problem to pin it down in Southern Europe. So I hate to ruin anyone's plans for a vacation in Southern Europe this year. But something very strange is going on. We're seeing the return of malaria to Greece and Italy after it's been gone for 70 years, around the time of World War II. We've now got schistosomiasis on the island of Corsica, dengue in Portugal, West Nile virus, chikungunya, Spain, Italy, and France. What's going on? Is that climate change? I mean, if you talk to the climate change people, they'll say maybe next to the Arctic, Southern Europe may be the next shoe to fall. But it's certainly not the only thing going on there. What else is going on in Southern Europe? Migration from where? From the conflict zones, right? People fleeing conflicts, coming across the Mediterranean from North Africa, or coming from Syria and Iraq. But what else is going on? What's happening to the economies of Greece and Italy? People are going like this, right? People are so the economies have collapsed. So what is it? Is it the economic collapse? Is it the human migrations coming across the Mediterranean? Is it climate change? And the answer is, we have no idea, right? Why don't we have any idea? We have no idea because right now, as we speak, we don't have a good way of untangling complex phenomena. So we have something like the return of all these neglected diseases to Southern Europe, and we don't have a good system of sorting out whether it's climate change or economic collapse or attributing the percentage to each of those things. And part of it is the fault of the kind of place where I work, with universities, right? We're very siloed. You know, right now, if you're an assistant professor of microbiology and want to be promoted to an associate professor of microbiology with tenure, you have to write and speak for other microbiologists, right? Where the academic system very much encourages you to stay in your lane. And so we don't have a good, comfortable mechanism at universities right now in the United States or in Europe for getting the microbiologists to talk to the political scientists or other social scientists, to the economists, to the earth scientists that are handling climate change. So we have to really think about how we're going to restructure our universities and also government agencies as well, right, if we're going to really solve some of these issues. Yes?
I would also try to break up some things in Southern Europe. I don't like travel much there anymore. There's kind of a hush-hush about the conditions in some of the refugee camps, settlements, and sanitation is just awful.
Sure. Well, certainly, for instance, we've now seen, for instance, that the leishmaniasis I told you about in Syria and Iraq has come into Lebanon in a huge way now, and so we are definitely seeing a component of that. I don't know how much of that is due to refugee movements versus other things going on. There's clearly at this point there's transmission within the community. The other factor, and I didn't put it on the original slide, but the other one we're starting to see now is urbanization. You know, if you talk to the population demographic people, they will tell you that by the year 2050, just about everybody's going to be living in what are being called megacities. And the megacities are more and more occurring in places like Lagos, Nigeria, or in Karachi in Pakistan. So by some estimates, the largest city in the world is going to be Lagos by the year 2015, with tens of millions of people living there. So we're starting to see now urban transmission of a lot of these diseases as well. So that's going to be another very important factor to look into. The other interesting force that we found is when we looked at the total number of people living with a neglected tropical disease, we found something counterintuitive. And that is when you look at the countries, the largest number of people living with neglected tropical diseases, while they're certainly in poor, devastated countries in Africa, by no means are they the only ones. What we're seeing on a numbers basis, and this is still taking us a little time to understand, when we look at the most of the world's neglected tropical diseases, overwhelmingly, it's people living in the group of 20 countries, the G20 countries. So what's going on there? What are the G20 countries? What's that? The 20 largest economies, right? Except for Nigeria, which is not a G20 country, but it has a GDP larger than the bottom three. And so when you add up the G20, the people living in the G20 economies plus Nigeria, they account for most of the world's neglected tropical diseases. Now you might say, well, you just told us that these are diseases of poverty. Why are they in the G20 countries? Our analysis suggests that it's the poor living in the G20 countries that now accounts for most of the world's neglected tropical diseases on a numbers basis. So this is the subject of my second forgotten book. It's called Blue Marble Health, and I wanted to give it a different name from global health, basically say, the traditional norms of global health, developed versus developing, that still holds true, but there's been a change, and maybe in part because of the interventions with the Millennium Development Goals. All economies are rising, but they seem to be leaving behind a bottom segment of society, and that's accounting for the world's poverty-related neglected diseases. So this is the most provocative map in the book, and it's basically showing you the areas of extreme poverty in the G20 countries, in the 20 wealthiest economies. And today, the G20 economies, together with Nigeria, now account for most of the world's worm infections that I've been showing you: leishmaniasis, tuberculosis, dengue, Chagas disease, leprosy, the list goes on. But they're in pockets. So for instance, if you go here to Argentina, you go up into northern Argentina, into the Chaco area, there's a lot of poverty, and this is where disease is. Or if you go into northeastern Brazil, where dengue arose in 2014, 2015, it's not just Zika, it's also dengue, leishmaniasis, Chagas disease, schistosomiasis. Anybody been to China in the last few years? So if you go to the big cities like Shanghai or Beijing in eastern China, they're incredible powerhouses, right? But then if you go into southwestern China, to Yunnan, Sichuan, Guizhou provinces, you go back in time 75 years, and you find widespread neglected tropical diseases and 175 million Chinese living below the poverty line. Okay, what's the most provocative thing I did on this map? The U.S. So does the U.S. have poor people? How many? A lot, yeah. So we just had last year the United Nations Special Rapporteur on Poverty spend several months in the United States touring the U.S. And his estimates are that we have 19 million Americans that live in extreme poverty, meaning at half the U.S. poverty level, and around 5 million Americans now living on less than $2 a day. And so the question is, and most of them are in southern states. So we started, one of the things that we did at our School of Tropical Medicine over the last few years, and I thought I knew what poverty, before we were in Houston, we lived in Washington, D.C., and I thought I knew what poverty looked like. But we came down here, and my wife and I just started driving around different neighborhoods in Houston, and we realized that poverty is a very different animal down here, that there's a level of extreme poverty here that not many people know about. And so we started taking that global health lens and kind of flipping it inward to get a better sense of what's happening in the United States. So we've just finished now a study, for instance, in rural Alabama, finding a significant level of hookworm transmission, one of the real classic neglected tropical diseases in Lowndes County, working with Catherine Coleman Flowers, who's an environmental activist. And Rogelio Mejia on our faculty has shown about a third of this population has hookworm infection, a disease which we thought was long gone. Which state has the largest number of people living in poverty? In terms of total numbers. Yeah, Texas. I mean, there's certainly a lot of poverty concentrated along the border with Mexico, and that's that lower left-hand picture. And you can see it looks like a picture you'd see in any global health film, right? It's got the discarded tires that are breeding Aedes aegypti mosquitoes, standing water, and dilapidated housing that allows vectors to come in. But it's not only along the border. So the top pictures are the ones that we took with Anna Grove, who's our grants and contracts manager. She's also a very good photographer, and this is in the 5th Ward of Houston, just a few miles from here. And you can see, again, the discarded tires, the housing without window screens or air conditioning. So we have been writing about this hidden burden of tropical diseases here in Texas. We're finding dengue, Christy Murray on our faculty, typhus transmission, Melissa Nolan, who was with us, now she's at the University of South Carolina, Chagas disease transmission, Rogelio finding toxocariasis. So our estimates are we have 12 million Americans living in extreme poverty with a neglected tropical disease. And that's been really tough concept to get people to care about. We had all that great success in advocacy getting people to care about neglected tropical diseases in Africa and the package of medicines. And I thought when we started writing and speaking about neglected tropical diseases in the US, wow, things will really take off. And quite the opposite has happened. Getting people to care about this issue in the US has been much tougher than getting people to care about disease in Africa and Asia. And why is that? By the way, generally, I'm genuinely asking, I don't know. I mean, all the tricks we use to get people to care about disease in Africa have completely failed in terms of getting advocacy and awareness in the US. Any ideas? Why? Yes? Assumption they'll be taken care of, yes.
Because they have to acknowledge the shortcomings of our system.
Yeah, I mean, I think all these things, yes, sir. So that's a very important point. So I actually went back to my usual guys at the White House and to get, saying, we're not getting any awareness. He goes, but Peter, when you told us about neglected tropical diseases in Africa, you told us 40 cents a person per year. Now you're telling us we've got to go into these communities and do active surveillance of these diseases. We've got to better understand the transmission patterns. What are the interventions? There's no way it's going to cost 40 cents a person per year. This is very complicated, and it's true, it's more complicated, but we're the United States. So I think this is a work in progress. So I'm in Washington next week. We've gotten a few people to care. Senator Cory Booker has gotten very interested in this, and others. So maybe we can get the problem is now getting this as a bipartisan initiative has been tough. We've gotten Chris Smith, who's a Republican congressman in New Jersey, to care, but it's been a challenge. So one of the things that we're doing now is trying to, the solutions for these diseases are complex. It's poverty reduction. It's what people call WASH, water and sanitation and hygiene, new medicines. My particular interest as a vaccine scientist is developing vaccines for these conditions. And what we've done is to set this up at the Feigen Center of Texas Children's Hospital. So this is the big research building of Texas Children's Hospital, where we've kind of set up what looks like a small to mid-sized biotech company, but it's making the vaccines that the big pharmaceuticals would never make, or what my kids lovingly call Dad's Guaranteed Money Losing Company. And so we're trying to explore doing this in the nonprofit sector. So we have 2 vaccines now in clinical trials for hookworm infection and schistosomiasis. And you can imagine this kind of map is not the map you want to see in your business plan, right, if you're a CEO of a company. So it's been, you want to see this in the United States and Europe and Japan, and it's actually quite the opposite. We've made a lot of progress on some of our vaccines. I'll just briefly tell you about them because we're low on time. For schistosomiasis, we collaborated with this team down here, Alex Lucas. He was with us. And now he's got his own lab in Australia, and we took a microarray approach to spot all of the proteins of the schistosome surface and then probe it with serum from resistant patients. And we were able to identify this surface antigen on the schistosome that's a highly potent vaccine that's protecting laboratory animals against infection. And we were able to convince the NIH to support us to go to phase 1 clinical trials to show that it's both safe and immunogenic, and now we're moving into phase 2 trials. The problem, and then I'll tell you the problem in a minute. Then for the hookworm vaccine, we take advantage of the blood feeding apparatus of the hookworm and interfere with its ability to feed on blood. We could do a whole hour lecture just on the science of this, and that's also gone through phase 1 trials. The problem that we're facing is we're getting kind of stuck, and the reason we're getting stuck is we're moving into phase 1 and phase 2, but then we don't have a financing strategy for getting to those phase 3 pivotal studies that will lead to licensure because the expense goes way up. It becomes millions of dollars at that point. And now I start realizing why it's only the big pharmaceutical companies that make vaccines, because you need that capital to get it all the way through phase 3 clinical trials. So the problem that we do have scientific hurdles, but our biggest problem, we don't think, are scientific hurdles, is we don't have the business model figured out. We don't have smart people from business schools and law schools that are helping us come up with, the point is we need as much innovation in the financial sector as we need innovation in the science. So lately when, I'm sure like many people here, we get a stream of young people committed to public service and faith and want to go into global health. And lately I've been disappointing them by telling them to go to business school or law school because that's where we really need the innovation right now. I think there's an answer out there. We just can't figure it out. So the exciting thing, doing this is no one's done this. No one's developed a vaccine in the nonprofit sector. The terrifying thing is no one's done this. No one's developed a vaccine in the nonprofit sector. So it's very much seat of the pants. And we're also now looking at vaccines for the United States. So this is a map of Chagas disease. And this is also very interesting because the Centers for Disease Control is saying, well, all of the Chagas disease is through immigration across the southern border, but we're finding transmission throughout many parts of Texas, including places like Hallettsville, Texas, and elsewhere. And this is work done by Christy Murray and Melissa Nolan. And we're even finding about 10% of the dogs are infected. And so I like to make the point that the dogs are not slipping across the border from El Salvador and Honduras, why we have transmission here as well. And so we have a very exciting vaccine known as TC24. And this gets to another problem that we have doing this in the nonprofit sector, is having access to what are called adjuvants. So anybody take the Shingrix vaccine? It hurt, right? It hurt. I was sore for 2 days after getting it. The reason that you were sore is it's a recombinant protein vaccine like ours, but it's paired with these immunostimulants that trigger local inflammation. That's proprietary chemicals tightly held by the pharmaceutical companies that we don't have access to. And so we're trying to figure out a way to get access to really stimulate the right type of immune response that we need. Which one? The BCG, yeah, to pair it with that, yeah. Some have thought about that as well, and that may work for this vaccine as well, for our Chagas vaccine, where we can block fibrosis in the heart. So that's getting exciting. And then we're also looking at how, and it's not just what vaccines we make, but how we make them. So many of you may remember, President Obama went to Cairo in 2009 and talked about reaching out to the Muslim world in the arts and sciences. And in that role, he appointed me as U.S. Science Envoy, and we focused on joint vaccine development with countries in the Middle East, with places like Saudi Arabia and Morocco and Tunisia and elsewhere. And now we're looking at how we can jointly develop vaccines because they have no capacity for making vaccines. So who's ultimately going to do the manufacture for that leishmaniasis vaccine in Syria and Iraq? We don't really have a good partner. So this is our prototype vaccine that we're doing jointly with the NIH. We're trying to see if we can enlist them to do the scale-up manufacturing because there's a lot of wealth in those Gulf Council countries, the GCC, like United Arab Emirates or Saudi Arabia or Qatar. Maybe they could be a part of the answer to this. We're also facing another hurdle that I never would have anticipated, and this is how I'll finish up and let you go, we've made an enormous success with global vaccination programs, and the one that was started in the year 2000 was Gavi, the Global Alliance for Vaccines and Immunization. And the idea was that we could do a better job scaling up existing vaccines and then incorporating new vaccines like the ones we're trying to do. So if we ever get to phase 3, this organization named Gavi is going to be very helpful for delivering new vaccines. The problem is we've got this new force that's been arising over the last 20 years, and it's euphemistically called the vaccine hesitancy movement, and it began in 1998 with a fraudulent paper that was published in The Lancet claiming that the measles, mumps, rubella vaccine causes autism, and that continues to be the central tenet of the anti-vaccine movement. And unfortunately now, the anti-vaccine movement, what started as a fringe movement, has now grown into its own media empire. By some estimates, almost 500 anti-vaccine websites, amplified on Facebook and social media. They're writing, fake books, fake documentaries. There's now political action committees in many states. And so we have this situation now. Even though we were about to control measles globally, now last year we had over 60,000 measles cases in Europe. So Italy's a mess, France is a mess, Greece as well. And in the United States, like all good trends, it started in California. The anti-vaccine movement, and particularly in Orange County and Marin County, where, and oftentimes the first breakthrough infection that you see is measles, because measles is the most highly contagious of all those diseases. So it has a reproductive number of 12 to 18, meaning if a single individual gets measles, on average 12 to 18 others get it. And those are classically infants under the age of 12 months, not yet old enough to be vaccinated. California had a horrific measles outbreak in 2014, 2015 that prompted the California legislature to say, wait a minute, we got to do something, because at that time, California was one of 19 states that allowed non-medical vaccine exemptions for reasons of personal or philosophical belief. And the California legislature closed that, and that has largely solved California's problem with a few exceptions, but the problem's largely solved in California. The problem, though, is everybody then moved to Texas. And Texas became the epicenter of the anti-vaccine movement. We can ignore some of these panhandle counties up here, I think, because they each have about 6 people in them, so if there's 2 not getting vaccinated. But Austin is a mess right now. Some of the North Texas towns, Plano, Denton, Fort Worth. Anybody from there? So what's going on in Plano? What's that? It's there, yeah. I mean, we still don't understand the social demographics of it. It looks like it tends to be wealthier populations and even educated, or as I like to say, educated enough to know how to do a Google search, but maybe not educated enough to know what the heck they're Googling because of this proliferation of anti-vaccine websites. This is the situation we have in Texas now. We have 60,000 kids not getting their vaccines in the state of Texas. And how many homeschooled kids do we have in Texas, which is the number I recently learned? Lots. How many? Anybody know? 325,000 homeschooled kids in the state of Texas. And the percentage of those not getting vaccinated is, drum roll, 20. We have no idea they're homeschooled, right? right? So there's probably over 100,000 kids not getting their vaccines in Texas. So we've now seen measles outbreaks, the same problem in Washington and Oregon, now in Texas. So wherever we allow these non-medical exemptions. So this has become a big issue. And I got involved in this because my youngest daughter, Rachel, has autism and intellectual disabilities and decided to sort of be out there and explaining the massive evidence showing there's no link between vaccines and autism, but also the lack of plausibility about that and the dangers of not vaccinating our kids. And together with a medical student, Jackie Olive, and our faculty member, Melissa Nolan, we started to track where these non-medical exemptions are. And you can see generally it's more Western states than Eastern states. So we're trying to understand what it is about Western states versus Eastern states. And these are sort of the hotspot areas, what turns out to be a pretty good predictive map of where we're going to see measles, right? Because we've seen measles here, and now in Texas. And we're trying to understand what it is about that. So I'm going to be in Washington next week trying to really figure out how we can maybe begin dismantling this media empire and shift policies around. I also talk about the lack of plausibility because we're starting to learn, this is me with Rachel, we're starting to learn so much now, not only about the evidence showing there's no link between vaccines and autism, but the lack of plausibility and how autism begins early in fetal development, prenatally in pregnancy, well before our kids ever see vaccines. So trying to get the word out about this. And I don't have time to go into this today, but we really are now understanding the 99 genes involved in creating autism and how it's absolutely not related to vaccines in any way. There's also a lot of interesting information, and I don't have time to go into this, about girls with autism, because we used to say it was 10-to-1 boys to girls, and now we realize it's probably much closer to 1-to-1 than we ever previously realized, just that girls on the autism spectrum are camouflage it better, they're more socially interactive, more verbal, but they have very high rates of comorbidities like obsessive compulsive disorder, attention deficit hyperactivity disorder. A lot of the girls with eating disorders are in fact on the autism spectrum. So it's really quite fascinating. So I'll end here. This is the third book I've written, and this is the one that's currently putting me in the witness protection program from the anti-vaccine people. And it just came out. It's called Vaccines Did Not Cause Rachel's Autism. And it provides the evidence showing there's no link between vaccines and autism, the lack of plausibility. Then tells a very personal story about our family, and we live in the Montrose area of Houston, just a few miles away from here, and what, the challenges Rachel faces. Not so much because of the autism, but in her case, the intellectual disabilities that she has with it, finding employment, how Goodwill Industries came to our rescue. It's a very interesting story. So I'll stop there with this statement from Elie Wiesel, who once said that man's weakness is not in achieving victories, but in taking advantage of them. We've made great strides through our rapid impact package, only to allow a lot of the NTDs to come roaring back through conflict and shifting social forces. And the same with vaccine preventable diseases, great strides, only to allow this anti-vaccine movement to take hold. So thank you very much for listening. I really appreciate your time.